right here. Now, I'm going to make sure you guys see everything or else it doesn't help. So we ended talking about types of bones. Compact bones, spongy bones. What's the difference? Well, the big difference is this. With compact bone, this is real dense. So dense that it's so strong, there's no way we can have room here for any red bone marrow. Remember, red bone marrow is where our stem cells are going to be found. The stem cells are where we're going to have a population that will differentiate and turn into your white blood cells, your red blood cells, your megakaryocytes that help us turn into platelets. So in order to have that red bone marrow, the one that actually is required when we're doing a bone marrow transplant, well, that red bone marrow requires space, requires room for those stem cells to be kind of hidden. Well, when we have dense compact bone, it's basically just bone tissue and cells that help make the bone tissue. So those, and with compact bone, it's really, really discussing, right? Not just one tree ring. One tree ring by itself is pretty strong, right? Remember, compact bone is a combination of the central canal and then these little black dots right here. So these little black dots are where we will see the osteocytes that make the bone material. And they all encircle this central canal, which is a blood vessel. And what happens is with compact bone, you have a very strong rings around that central canal of bone tissue. Then next to that ring, then you have another ring over here of real strong bone tissue. And then another one on the side, and another one over here, and then another one over here. All of them super strong individually, but now you have many, many thousands of them clustered together, each giving us additive strength, making it super strong. Not unbreakable, but super strong compared to the other type of bone tissue. We call that compact bone. Now, the Volkmann's canals are little breaks that are found that allows us to bring nutrients from the central region to the other cells. Let me just make sure everybody is in mute. All right, so when we're looking at that, the Volkmann's canals and everything, keep in mind that now remember, the test, this next quiz will be online. So, you can look things up right here. With Volkmann's canals, perforating canals, they're the same thing. They allow us to direct flow. Because remember, you have cells way out here. You need to bring nutrients to those cells. This is all dense bone tissue found in the matrix. So oxygen can't just diffuse through that real dense bone tissue. So we need our little perforating canals and little connections between cells to cells that allows us to bring nutrients from one cell to the next, right? And to bring new blood into the central canal region. Now, kind of talk about the compact bone. They're formed by osteons with a central canal in the middle. The rings of tissue are called lamella. So lamella are just the rings of bone tissue that surrounds that central canal. Concentric lamella are ones that are immediately close and surrounding the actual central canal region. Then, right, we have circumferential ones that are at the edges, and then interstitial ones that basically helps bind one osteon with another. So interstitial ones will be over here. The circumferential ones will be way in the back area right here. Right. So now with the bone anatomy, keep in mind when we talk about these are 4 different categories of bones: long bones, short bones, flat bones, irregular bones. Right. The long bones can be something as long as your femur, your humerus, radius, ulna, your tibia, fibula. Those are all long bones. But your metacarpals and your metatarsals are also considered your long bone as well. Your phalanges are pretty long. They're considered long bones, even though they're pretty short compared to your femur. Now, the short bones are the ones that are carpal bones. Now, metacarpals and carpals are different. And we'll go through that a little bit when I will take some time today and go through the bones of the wrist. Then you have irregular bones that look like a little bat or a little butterfly here. This is a sphenoid bone from the skull. And then flat bones usually make up protective layers of bones. So we see it as a parietal bone areas of the skull, as a sternum. Ribs are considered flat bones in that it allows us to protect the internal organs. Now keep in mind, all bones are combinations of dense compact and spongy. So you can imagine if we're in the skull right here, yeah, we want protection. But if it was basically all dense compact bone in our skull would be like 10 pounds. And that's before adding the weight, another 2 pounds of weight for the brain and all the fluid. So that would make it pretty heavy. So what we have to lighten up our load here is a combination of dense compact bone on the outside, then spongy bone on the inside. See how we have combinations throughout. The shaft is a long aspect of the actual bone material. And the shaft is usually called the diaphysis. And the diaphysis is made out of compact bone. Then on our long bones, we have two ends, right? One end closer to the rest of the body, we call the proximal end. And then one end that's a distal. So here's the femur right here. The proximal end is the one that's going to make contact with our hip, forming our hip joint. Remember, the hip joint is a joint. It's not just one bone. So when you have a hip joint, it's formed by the head of the femur as well as the acetabulum of the hip. So what we're going to see here is this. The head of the femur, the greater trochanter of the femur, and the diaphysis or the shaft are made out of different combinations of bone. The diaphysis has to be really strong because it's got to support your body weight. Think about what happens if you're standing up or you're jumping and you land on one leg. That happens a lot, right? Or you push off on one leg. That's a lot of stress you're putting on one leg. Primarily, that stress is going to go to this femur. We don't want it to just break because of your body weight. So the shaft region has to be dense, compact bone. And again, the shaft is also known as a diaphysis. The end right here, the epiphysis, and this is where we get the name, the epiphyseal growth plate. The epiphyseal growth plate is found at the ends, and that's where we're going to have lots of cartilage. This cartilage, we're going to see this cartilage has been there ever since we first make bone. In utero, the bone material is actually made out of cartilage. So this epiphyseal growth plate has been with us since our bone was first made out of cartilage. So this epiphyseal growth plate is found on both ends. So this is why we get the name epiphyseal growth plate, because epiphyses are the ends, and we have a proximal end here. And then if they continue this bone all the way down, then we'll see near where the knee is, the distal end also has an epiphyseal growth plate. Now, it kind of makes sense, right? When we want to grow taller, and we are hitting puberty and getting taller, we want our bones to get taller from the top up and from the bottom down. So then it doesn't just grow in one direction, it grows in both directions at the epiphyseal growth plate. Once we have attained full adult height, the growth plate is completely replaced from cartilage tissue to bone tissue. At this point, you have sealed the growth plate, and instead of cartilage now, we see a line of bone tissue that we call the epiphyseal line. By the way, this is how we can tell if a child still has room to grow or they have hit their full adult height. Periosteum, and this is pretty interesting right here. Periosteum is an outer layer. The inner aspect of this outer layer of bone tissue is this inner layer contains cells that are your osteochondral progenitor cells. So these are the stem cells that can turn into osteoblasts or chondroblasts. So that's pretty cool. You have this layer that allows us to reform bone, to reform new bone forming tissue. Fibers of tendon become continuous with the fibers of the periosteum, meaning that with the tendons, like your biceps tendon, your biceps is found in your anterior arm. They're the main movers of your elbow, allowing you to flex the elbow. Well, the cool thing is this, the tendon is a connection between the muscle to the bone. Think about your Achilles tendon. Your Achilles tendon allows you to connect the muscle of your calves, right? You're gonna have two incredibly strong muscles of the calf. That's your gastrocnemius and your soleus. Those muscles are then going to come down, form this huge muscle, and then turn into a tendon, the Achilles tendon, as it turns and it connects to the bone. Well, we don't want that tendon to rip off the bone. So that would not be good. To reinforce that tendon, we see that the tendon actually becomes part of the external layer of bone tissue. It becomes continuous with the periosteum, making it part of the bone as it goes and inserts into our calcaneus or our heel bone. So all of our tendons are going to go into the bone. It's going to connect with the bone or insert on the bone. As it inserts to the bone, it actually becomes part of the fibers that make up our periosteum. It becomes part of the bone tissue. That strengthens that connection because now it's part of the bone. Now, to further increase the strength, so then we don't rip the Achilles tendon, well, to further straighten it, we have Sharpie's fibers. These are periosteal fibers that penetrates through the periosteum into the bone. They strengthen the attachment of tendon to the bone even more. So you can imagine, right? What do you do when you want to connect two things that are not usually connected? Well, you'd want to somehow either stitch those two pieces together or you want to tack it in place. And that's what we see here. With Sharpie's fibers, we know that your tendon is going to come in, it's going to become part of periosteum. But that's strong, still not strong enough. So I'm going to have a nail that I'm going to push all the way through. So then I virtually make it impossible for this periosteal layer to separate from the bone tissue. It really strengthens our tendons then. Most of the time when people rip their Achilles tendons, they don't rip it away from the bone tissue. They rip it where the muscle tissue is found. Why? Because in the muscle tissue, you don't have these little strengtheners here that allows us to have very strong connections between the actual tendon to the bone. Now, the best example I have to give you is actually food again. All right, you guys have all eaten a drumstick from a chicken versus a drumstick from a turkey. Have you ever, for a chicken, when you eat the drumstick, that's their tibia, by the way. When you're eating the meat from the tibia, you're eating the calf muscles. I know, it's gross, right? So as you're eating that muscle tissue, you can see that the tendon itself that connects the muscle to the bone, it's not super strong, right? It's not super strong at all. You can rip the tendon off the heel. Now, if you've ever had a turkey leg, right? And try next time if you eat a turkey leg at State Fair, we can have one, right? If you eat a turkey leg, next time try to rip the tendons off. It's impossible, right? And the reason why is because they have a lot more Sharpie's fibers that connects those tendons in turkeys. This lecture is great right before, immediately before our Thanksgiving lectures usually. So review this in terms of the long bones. Flat bones, again, protective, a sandwich between dense, compact bones on the outside and a middle layer to lighten it of spongy bone. Also, spongy bone is very sharp. The last thing we want to do is have all these sharp fibers. So if you put your hand over spongy bone, it's incredibly sharp. It can cut. So What we don't want is just this layer of spongy bone to make contact with our meninges and our brain, or even our lung matter. All right, it will cut into the brain and lung matter. So what we want to do is have another layer of dense compact bone on the inside. Dense compact bone is smooth and strong, but it's heavy. Short and irregular bones are very similar to the epiphysis. We have a very small layer of dense compact bone externally, and then a large layer of spongy bone. Right. Two main types of bone formation. Now we're talking about fetal development here. So in utero, how do we make bone? There's two main types of bone formation: intramembranous ossification, endochondral. Now the easiest way to understand it is intramembranous, one step. You have stem cells that are really early on in gestation. They migrate to the area where you need that bone, and immediately those stem cells turn into osteoblasts and starts building bone tissue. No intermediate stage of bone formation where we make cartilage first. Endochondral requires formation of cartilage matrix first. So it's a two-step process. You're gonna have stem cells migrate to the site where you need that bone. Then those stem cells turn into osteochondral progenitor cells. And then those cells turn into chondroblasts first. And they start making cartilage first. As you start making more and more cartilage, then the cartilage bone matter is going to start to grow. But you always make cartilage first. Then a little bit later on, about 8 weeks later, then we start replacing the cartilage with bone. Now, after we're done with ossification, you cannot tell which way we made that bone originally. So we have two main types of ossification, but by the end of both types, there is no difference in the type of bone that is formed. It's how we formed it that's different. Now, in terms of intramembranous, what I want you to understand is very generally, how is it formed? Basically, stem cells migrate to that area, and again, all right, and they start building bone. No cartilage is formed, no other kind of intermediate is formed. Now, what we will see here is that many bones of the skull, even a part of the mandible, part of the clavicle, that's how we form, is formed by intramembranous ossification. So the fontanelles, I don't know if you guys have ever like taken care of a baby, but when you see a little infant, infants have soft spots in their skulls. Those soft spots are called fontanelles. And fontanelles are unossified areas that will then need to be kind of ossified, right? That's an example of this intramembranous ossification. Bone forming stem cells migrate to that area. Then they start to populate that region. Then the stem cells turn into osteoblasts once they get into that area and start forming bone tissue immediately. The big thing is understanding that there aren't a lot of bones made by intramembranous ossification. So frontal, parietal, mandible, part of the clavicle, that's it. The remainder of bone in our body, which is a lot, is going to be formed by endochondral ossification, right? With endochondral ossification, this is how we make all of our long bones. What happens with endochondral ossification is cartilage formation occurs first, and it begins at the end of the 4th week of gestation. So even before some people realize that they're pregnant, we already have this endochondral ossification starting. Now, the weird thing is this, right? At about 8 weeks, we're going to start replacing some of the cartilage. So we form cartilage matrix first, where the bone should be found. And then a month later, we start replacing some of that bone tissue with real bone tissue, the cartilage tissue with bone tissue. Now, in some people, you don't really finish endochondral ossification until you're 20 years old. By the time you're at the end of puberty, Now, again, you're like, how is this that long, right? Endochondral ossification is how we grow our bones when we hit puberty. We're going to replace cartilage with bone. That's how we grow in length. Now, with endochondral ossification, it's a two-step process, beginning with our stem cells. Those stem cells then migrate to that area of our long bones that requires lots of strength. Immediately, they form a perichondrial layer, which allows chondroblasts to differentiate. As they differentiate, chondroblast starts forming cartilage template. And then a month later, we start replacing that cartilage with bone tissue. And here, easier to see the picture. So right away, at about a month into our gestation, we're going to start forming this collar that's called the perichondrium. The perichondrium is going to have all of our stem cells. Remember, stem cells here can either turn into cartilage or can turn into bone-forming cells. So they're very related, these stem cells. So the stem cells migrate to that area. They turn into chondroblasts. They start forming this cartilage tissue, and that's what happens through all of our long bones. And then at about a month later, we have an area right in the middle of our bone tissue, right? Remember, it's all cartilage first. This cartilage material starts to die off. A blood vessel penetrates through and brings in osteoclast. The osteoclast then starts to reabsorb that cartilage, and then osteoblast starts to migrate inwards. As they migrate inwards, you start replacing cartilage material with new bone material, because now we have osteoblasts in this area right here. Right? That area where the blood vessel first penetrates is called the primary ossification center. And this happens through all of your long bones, right? You form it out of cartilage, then a month later, you have cell death occurring here, apoptosis, programmed cell death of the cartilaginous cells, those chondrocytes, that allows a blood vessel to penetrate, allows us to bring osteoclast in so then we can resorb that cartilage. Then osteoblast differentiates and starts to replace what was cartilage material with bone material. Now, at the primary ossification center, we start to replace bone tissue from the middle area upwards. Right? Middle area up, middle area down. So it starts at the diaphysis and spreads up and down. Now, the ends, the epiphysis, this area never migrates all the way up yet, right? In order to have bone tissue at the epiphysis, we need a secondary site of ossification. So at the ends, you have cell death occurring here. Now you're going to see in a second, a blood vessel penetrate through again, right? Bringing more osteoclast, right? Reabsorption of bone occurs. And now we're going to bring osteoblasts to now start forming bone material. So at the ends, you start having this secondary ossification centers. And what we're going to see is, remember, right? The shaft, you're going to have bone replacement from the middle up. The ends, you're going to have it from the midpoint of the shaft outwards. Right? Again, now we have more bone replacement. Now you have seen that spread of bone tissue and the replacement of bone tissue, replacement of cartilage tissue with bone tissue right here. See how much bigger this area has gotten? That's because the bone tissue has spread out, right, and replaced the cartilage tissue. Now, there are two places where we don't replace cartilage or replace bone with cartilage. The two places are one where the shaft or the diaphysis meets the epiphysis. This region that is still cartilage right here that we don't replace, that will become our epiphyseal growth plates. Remember when I mentioned that your epiphyseal growth plates have been with us since our bones were made out of cartilage? This is why it's been with us since our bones were made out of cartilage. It's a part of the bone matter throughout a whole long bone region, all of it, right? That's a region that never got replaced with endochondral ossification early on in gestation, right? So this epiphyseal growth plate is really old cartilage. Then the second area that we never replace with bone tissue is at the very edges. The very edges, that bone tissue is never replaced. Instead, we have cartilage matrix still here. That turns into articular cartilage. Remember, articular cartilage usually is found at the joints, and articular cartilage is a kind of cartilage that allows for smoothed out movements, prevents bone to bone rubbing. So that when you hear people having degenerative joints, degenerative knee disease, right? It means that the articular cartilage has started to wear down prematurely. So when you have people that are 80 years old, well, they're not going to have degenerative, joint disease because they're older. Usually when you're 30, 40 years old and you have bad joints, that usually means you have an erosion of this articular cartilage, worse than what a normal 30, 40-year-old should have. Or God forbid, teenagers have this sometimes, athletes, right? So this articular cartilage, the epiphyseal growth plate, are two areas of cartilage that does not get replaced with bone tissue. This one never gets replaced with bone tissue. It just wears out. This one over here eventually does as we grow in length and height, right? And then we hit our full height and we seal that plate. So eventually this area does get replaced with bone, although the articular cartilage never does. Right? Bone growth, right? Growth in length, growth in width. Now this is where it gets kind of confusing because it's completely opposite when we talk about bone growth and cartilage growth. Growth in length occurs only at the epiphyseal growth plate. Makes sense. In order for our bones to grow in length, we need cartilage to be present. We need that epiphyseal growth plate. The larger the epiphyseal growth plate, the more room you have to grow in height. This is called interstitial growth. So interstitial growth of bone is growth in length. Involves formation of new cartilage, occurs at the growth plate. Growth of the cartilage on the superior and inferior sides allows for growth of the bone bilaterally on both sides. Once we have hit our full adult height, then we have greater appositional growth, which is the growth in width. Now, if you, again, right, next time you eat a duck, next time you eat a chicken and you eat the drumstick, I want you to look for the small fibula that is on the outside of the tibia. So again, the drumstick is a tibia, and then you should see a very, very small bone. That's your fibula. The fibula will be what happens, and how small and narrow it is in chicken, is what happens when there's very little appositional growth. You guys know that when we harvest a chicken, right? When we take the chicken to slaughter, usually they're really, really young. That's why their fibula is so small, is because the chicken is so young that you don't have this appositional growth in their fibula. Instead, you have length occurring. The fibula is very tall, very long, but because there's no appositional growth, that fibula in the chicken is very, very, very narrow, very thin, right? So it's because of how old that chicken was when we first harvest that chicken. I know if you guys are vegetarians, I apologize, but it's probably easier to look at the comparative anatomy because we can't look into our own. Most of us are not going to look at a cadaver. Most of you are not going to be able to look at your own bones and actually visualize it, right? Unless you have an x-ray around somewhere. So probably the easiest way is to try to connect it with what we do see a lot, which is food. Now, The articular cartilage does not ossify, persists throughout life. Epiphyseal growth, which is growth in width, occurs after closure of the growth plate. So highlight that. That's really important. So after closure of the growth plate, after you have fully sealed the growth plate, then you'll have increased growth in width, making it much, much stronger. How does this work? Probably easier to look at a picture. So here is our tibia right here. So this tibia, this is the proximal end. Remember, so here's a tibia right here. So this is the femur. If you take a look really closely, it looks like there's a break here, right? That's not a break. Remember, bone tissue is very dense. So x-rays can't get through the bone tissue and it comes back up or gets absorbed. So anything that's really dense appears white because x-rays can't get through. If there's no tissue, then x-rays goes through because there's nothing to kind of absorb that x-ray. And that x-ray will then cause that film behind you to turn black. Anything with mass, anything with density absorbs the x-ray. X-rays can't get through and it appears bright white. So the thicker something is, the lighter in color it is. It's like a negative image. Now what else? Cartilage is made out of something that is thick. So when the x-rays goes to the area of the cartilage, it causes that region to look black or empty. Well, the epiphyseal growth plate is made out of cartilage. So when x-rays go through it, there's not as much density there to absorb it. So the x-rays goes right through. This is your epiphyseal growth plate. Again, this is the distal epiphyseal growth plate of your femur. If they move it up, we should see a proximal one near the hip. Here is the tibia. Here's the fibula. Notice in the fibula as well, you can see what looks like a little area where there's a little black line here. That's an epiphyseal growth plate of the fibula, the proximal part. Here's a proximal epiphyseal growth plate of the tibia, right? Tibia is thicker. Tibia looks like a triangle, right? Your shin bone is your tibia. Now, what happens and how do we grow? On the proximal side right here, we're gonna see, right? We're gonna take a look at a diagram. This area right here, that's a growth plate. There's a growth plate right here. What happens with this interstitial growth is that the cartilage closest to the end right here, that cartilage line right here starts to activate. As you start to activate, you start growing the cartilage upwards. So at the superior line right here, cartilage differentiation occur, and you start forming more chondroblasts. Those chondroblasts start building cartilage upwards. As the cartilage moves upwards, on the bottom here, bone tissue replaces the cartilage. So what happens? As the cartilage extends up, bone tissue behind it starts to replace all that old cartilage with new bone. So as soon as that migrates up, we replace it with bone from the bottom. The more this migrates up, the more bone tissue that we place from the bottom upwards. Eventually, what happens is this, right? You have more cartilage growth, you'll have more bone growth. You have more cartilage growth, you have more bone replacement. Perfect. Now we're growing upwards and our shaft is becoming longer, which will make our bones longer as well. Now, eventually with time, the cartilage growth slows down. Our bone formation never slows down. So then eventually as a cartilage starts to slow down its movement up right here, the bone osteoblast will take over and seal that plate. When that happens, well, what happens? Right? I've had a lot of cartilage growth up here. And now the cartilage should be way up here now. And now bone is going to replace it. And bone will eventually catch up to the cartilage. And now at this area, we're going to have all bone replacing that cartilage. What have I done? At the very start, our bone of the shaft started here. By the time we're done, the shaft is extended upwards about 1.5 inches. Now remember, that happens in this side, the proximal side, as well as the distal side where you have your ankles. So then you're growing in both directions, right? You're growing bone upwards here. You're growing bone way in the bottom, downwards as well. So that's what we mean by bilateral growth, right? Again, in order for bones to grow in length, you need cartilage growth. The cartilage is going to grow upwards on this side. On the bottom, it's going to grow downwards. So then, as a cartilage grows up on this proximal aspect of our tibia, as the cartilage on this leading edge migrates upwards, bone is going to get replaced from the inferior edge upwards. As long as you have lots of cartilage growth, you're going to have bone replacement from the bottom up. Now, in most of us, 99% of us, right, once you hit about 15, 16 years of age right here, the cartilage growth slows down. As it slows down, the bone growth takes over and seals that cartilage. At that point, there's no more growth in length possible. You have hit our full adult height at that point. And the reason why is simple. There's no more cartilage here because you've already sealed that cartilage with bone material, right? And again, cartilage growth is required for bone growth. This is interstitial bone growth right here, growth in length. Now, eventually, right, we're going to have our tibia and your femur as well, right? In the femur, which they don't really show on the diagram, right, you see this bottom edge right here? Well, that's going to be where cartilage growth is going to occur. And this edge on top, well, that edge is where we're going to replace with bone tissue. So cartilage is going to grow downwards over here. And then bone is going to start replacing it from near the shaft down as well. So the more cartilage growth, the more bone can grow. Now we've extended the bone a little bit. Now you have heard of people like Anthony Davis, who plays for the LA Lakers, that when he was a senior, I believe it was like the end of his junior year in high school, he was a 6'2", 6'3" point guard. Really good, but not really, you know, he didn't have the skills to be like a #1 draft pick, definitely. Didn't have the skills to be playing with some of the big universities. But over the summer, between his junior year and his senior year, he grew 6.5, 7 inches, which is crazy. And instead of becoming a point guard, now he had the skills of a shooting guard, point guard, and now he's 6'10". That does happen every once in a while. Now, once we have bone growth in length, then we can start growing in width. Bone growth in width is appositional growth. And what happens is this, right? Where our edge of our bone was. So this is the very end of our bone on the outside, right? To make our bones wider, we place a new blood vessel on the outside rim of the bone tissue, our periosteum. Then, as soon as we place a new blood vessel there, the periosteal layer, or stem cell layer, is going to migrate and enclose around this new blood vessel. See that? It's like a wave, and it's kind of encloses that new blood vessel on the outside. And as it does this, it encloses a blood vessel. That blood vessel will then become the central canal. And then all these osteoblasts fills in from the outside in. What have I done? Right? This area used to be the very end of our very thin bone. Now I have extended it a little bit, making it a little bit wider. That is appositional growth. So once I have this area, now I have an osteon on the outer edge. I still want to make it wider. So I'm going to put another blood vessel right here. As we have another blood vessel that we'd add over here, then the periosteum is going to encircle it. And now I'm going to extend the osteon a little bit more on the outside, making it even wider and making it stronger. Perfect. Now, what are some of the factors affecting bone growth? Obviously, nutrition is a big one, right? Size, shape of a bone determined genetically, but can be modified and influenced by nutrition and hormones. So one of the nutritions, and the big one, is vitamin D. Vitamin D is a decavitamin. A decavitamin means that these are fat-soluble vitamins. The only way you can absorb it is if you have fat or oil. That's why you always see vitamin D in a capsule. And that capsule has a little bit of oil in it. So if you have vitamin D tablet or capsule at home, right, with one of the actual pills, I want you to take a needle and just puncture through it. And what should come out is a little bit of oil. That oil is a vehicle for us to absorb that vitamin D. Same thing with vitamin E, A, and K. These decavitamins are our fat-soluble vitamins. If you have it as a tablet, like you would have Tylenol, you wouldn't absorb that vitamin D. In order to absorb it, you need it with oil or fat. If you don't have vitamin D, you have rickets, lack of vitamin D during childhood. In adulthood, you have osteomalacia. Now, vitamin D also requires you to supplement with calcium. We'll see why in a second. Now, what else do we need? Vitamin C. Vitamin C is necessary for collagen synthesis by the osteoblasts. Collagen is the framework of both cartilage and the bone tissue. Remember, collagen is the organic matrix. And then on top of that organic matrix, then we add calcium phosphate on top. Without vitamin C, you have scurvy, right? Deficiency of vitamin C. You see people that are sailors back in the old days, they'd get scurvy all the time. And even in areas where you don't have citrus, you still have people now that can get scurvy. Especially, you guys have heard of people taking a real strict protein diet. Well, usually when you have a real strict protein diet, they don't allow you to eat fruits. And if you're not taking vitamin C supplement, you can get scurvy as a result. Hormones. Hormones including growth hormones and sex hormones, such as estrogen and testosterone. So growth hormone obviously is very, very, very intense, very strong, right? Growth hormones are naturally released from our anterior pituitary, stimulates both interstitial cartilage growth and appositional bone growth, right? So what happens? It allows us to have growth in height and in width. So what happens is we give somebody that hasn't hit puberty or has just started hitting puberty, if you give them a certain amount of growth hormone, they will become taller, right? That's why we usually give it to people that we know are going to be short. Now, we can't give it to people who are achondroplagic. So little people, right? People with dwarfism, human growth hormones, and the treatment with human growth hormones doesn't work. The problem with little people is that they usually have a mutation in a gene for collagen, all right? And because of that, even if you give them growth hormone, you still make bad collagen still, right? So genetically, it's just a problem with the collagen formation. Now, if you have somebody that is going to be short, 5'1", 5'2", right? And that's going to make it really hard for them to do what they want. Then some doctors will assign and treat with human growth hormone. Now, the more common way of treatment with human growth hormone is elderly people who have osteoporosis. People with osteoporosis, they have a lack of bone density. Human growth hormone is incredible in terms of treating osteoporosis. And usually with human growth hormone, it builds a lot of muscle. And we have seen that it actually helps cognitive decline for some people. So most of the time when you hear about athletes getting human growth hormone, they don't get it from their doctors. They get it for clinics that cater to the older population, for people who are elderly, because it's really good for bone deposition. Um, Thyroid hormone, another hormone that increases the bone density. Estrogen and progesterone as well, right? Cause growth at puberty, but can also cause closure of the epiphyseal growth plate and premature cessation of growth. Estrogen is a much more potent stimulator than testosterone. This is one of the reasons why when you look at like an 8-year-old or even a 5, 6-year-old little girl and compared to a little boy, they look very similar. But at 10 years old, usually the girls are a little bit taller, right? And the boys are a little shorter. Why? Well, even at 12, 13 years old, the girls are a little bit taller because of the presence of estrogen. But when you take a look at it when they're high school juniors, right? When they're 15, 16, 17, usually the boys caught up or are even taller, right? Because of the lack of estrogen, the testosterone dominates, and testosterone allows for steady growth with time. Estrogen allows you to peak and it comes back down. That's it. As it goes down, it allows you to hit a peak, seal your growth plate. You get taller real quickly, but you don't attain usually the full height that you might have. Right. Bone remodeling and remodeling means, remember, two things. One, when we have fractures, or two, when we want to replace old bone tissue with new. Areas of stress usually have more bone remodeling. So near your knee, your hip joint, right? Your disc, your vertebrae, you're gonna have lots of bone remodeling. Now, it also makes sense because if you've ever had braces increases the stress in the area of the teeth and your jaw that you want to move the teeth. So the more stress, the more bone repositioning we will see, the more bone remodeling. Bone remodeling converts woven bone into lamellar bone, caused by migration of basic multicellular units, which are groups of osteoclasts and osteoblasts that remodels bones, involved in bone growth, changes in bone shape, adjustments in bone due to stress, bone repair, and calcium ion concentration. Relative thickness of bone changes as the bones grow. Bones are constantly removed by the osteoclast and replaced by osteoblasts. That's a big one. Continuous replacement. So then you don't have just old decayed bone. Right? So here's just a picture of the bone remodeling. Probably the better example is what happens with mechanical stress. Two examples, right? One, gravity, lack of gravity. So when you guys have probably heard of John Glenn, right? John Glenn was one of the first persons that went into space. And when he first went into space, he was like 35, 40 years old. And then when he was 80 years old, just a few years ago, he went back to space. Now, when you go into space, they do lots and lots and lots of lab work, right? They need to do lots of experiments. Well, when he went, he was the experiment. Why? They wanted to see how much bone density he would lose when, as an elderly person, he would go into space. Here's why. Without in space, there's no gravity. Because there's no gravity, there is no stress. Inherently, then, we would start losing bone deposition and bone mass and bone density. So if you've ever seen people, astronauts in an international space station, they're almost always either doing experiments, sleeping or eating, or exercising. The reason why is simple. If you don't exercise, you don't have the ability to remodel bone. Bone then, in the absence of stress, it starts to dissipate and you start losing bone density, right? So to combat that loss of bone density, all the astronauts have to do many hours of exercise. That exercise, that weight-bearing exercise, will then allow them to hopefully offset the bone loss, right? Because they're doing and putting a lot of stress on the bones by exercising, it will then hopefully deposit some bone. Now, you will always lose a little bit of bone matter, right? So you've seen people that are in the ISS, right? When they first go into the space station, you see them, and tell me if you have ever seen pictures of the astronauts going into the capsule, going into the space shuttle, right? How many times have you seen people leaving the space shuttle, leaving the actual, right, the rocket when they're about to, when they're done with their mission? Usually never. The reason why is this: it's really bad luck to show an astronaut whose bone density and muscle strength are so weakened that they can't walk out of the space station. They can't walk out of the space shuttle. And usually that's what happens, right? Usually they're in a wheelchair when they come back, right? The reason why is simple. They've been up there so long that they had a lot of muscle and bone loss. And then when they come back down, right, not only is the muscle and bones weaker, but now gravity actually plays a big role in our cardiovascular system. So they might faint, they might fall. The last thing you want to do is have your astronaut come out, fall, break a leg. Not good. Or pass out, right? That's not good either. So you seldom ever see the astronauts as they're returning. You usually see them when they're leaving. Now, if it is a space shuttle and you're only up there for a week, 2 weeks, you might see them on the way down. But if they have had to stay in the International Space Station for 3, 4, 6, 12 months, you will never see pictures of them when they first exit their vehicle, right? So again, stress plays a big role. Now, also with stress, think about what happens with braces. When you wear braces, you put stress on the teeth and therefore the jaw, the mandible, or the maxilla. The more stress, the more bone building you'll have in that area. The more bone resolving in the areas where there's less stress. So then you're able to move the teeth, so then they align. You don't need to know about bone repair. Right? Review this calcium homeostasis for the quiz. Again, probably easier to look on a picture. With calcium, when there's a lack of calcium right here, right? What happens? And follow this down. When there's a lack of calcium, we're going to release parathyroid hormone, PTH. PTH is very similar to vitamin D, and they work concurrently. So PTH is going to cause a release and formation of vitamin D from the kidneys. PTH is going to stimulate osteoclasts to reabsorb bone and remove calcium and release it in the bloodstream. Remember, right? The stimuli here is decreased blood calcium, right? So now the calcium is going to come from your bones, go into the bloodstream, hopefully increasing it to normal. Now, the next day, you'll always excrete a little bit of calcium from your kidneys. You'll always release a little bit of calcium from your intestines. So you will always have loss of calcium. So this feedback system was there to just slightly increase it towards normal for that day. The next day, if you don't get enough calcium to the diet, you'll have decreased blood calcium again. And you'll have this occurring again the next day. You're going to be eventually breaking down more bone than you remodel, right? Now, the good news is, as long as you take vitamin D, as long as you take calcium, we can then offset this, right? If after the next day you take vitamin D and you take a calcium supplement with it, then I can increase blood calcium because I'm taking that supplement, which will then stop PTH from being released. Because I stop PTH from being released, I don't stimulate the osteoclast. Even better, when I have increased blood calcium, I'm going to stimulate from another group of cells by our thyroid, right? Calcitonin releasing cells releases calcitonin. That further inhibits osteoclast, meaning I slow down, basically stop the breakdown of new bone. Remember, why? It's because I already have enough calcium in my bloodstream. And since I have enough calcium in the bloodstream, calcium from the bloodstream then gets moved into the bone, and I start to add calcium phosphate to the bone, building up more bone than tearing down. At that point, I build bone, and I'm going to offset osteoporosis. Our body only is worried about our blood calcium levels. That's a big thing, right? It's worried about levels of calcium being high or low in our bloodstream. If your blood calcium is really low, we will keep breaking down bone. It doesn't matter. You will keep breaking down bone to increase our blood calcium levels. It is up to you by way of diet to get enough so that we can build bone as well. Because if you have a bad and low calcium diet, well, women at this point, most of you guys are not menopausal age. Well, once you hit menopause, then it becomes a bigger issue. Before you hit menopause, you have progesterone and estrogen, both offsetting that bone loss. Once you hit menopause, then you no longer have that huge influx of estrogen and progesterone. So if you have a bad diet, then, and you don't take enough calcium in your diet, you're going to have this occurring on the left. More breakdown of bone every day. Then you will have buildup of bone. Eventually, your bone density is going to be super low. So kind of review this for osteoporosis. We kind of mentioned it. You don't have to know the fractures. All right, again with bone, in terms of osteoporosis, both blood for blood clotting, muscle contractions, and for neurons to work, we need free calcium, right? There's only one place where it's stored, it's in the bone. So if you don't get enough calcium by diet, guess where we're gonna get the calcium from, right? That calcium needs and is required in the bloodstream. So if you don't get enough, we're gonna break down more bone. And we keep breaking down more bone, right? Eventually, your bone density is gonna drop, putting you at greater risk of fractures. Now, who are most risk, right? White, thin, postmenopausal. I know this is kind of funny the way we say it. So white, thin, postmenopausal smoking alcoholics that usually have a family history. I know, crazy, right? So why thin? Well, the more weight, the more stress, the more bone building, right? We know smoking and alcohol plays a big role in terms of both what happens when you're smoking and drinking, usually not exercising, right? And females, especially postmenopausal females, are more likely to have this. And this could be Asians as well, right? Anybody who is thin are at greater risk. It's one of the rare times when being slightly heavy is actually okay, right? Not super heavy, but slightly heavy. Now, the weird one is this. These people, women athletes, are also usually more prone to it. Why? Women who are either too thin or too muscular because of exercise. If you've ever seen the US women's soccer players, the US women tennis players, US women, right? All of our US women athletic teams, they're incredibly built. It's great, right? You can see just how in shape they are. Usually though, their muscles and their fat density is not that high. Their fat composition, right? For women, you need at least about 16 to 18% body fat for women to have normal menstruation. People who are actively training for a sport, really at a high level, women who are at that level really don't have a lot of body fat. And usually they actually stop menstruating. And because they have menstruation that's lost, then estrogen levels decline as well. As the estrogen levels decline, they're at greater risk for osteoporosis, which is crazy, but that does happen. And you guys have probably heard of like people who have like bulimia, that have anorexia, that got really thin and that they lose their ability to menstruate. Anytime you mess with that cycle, there's a chance of, premature osteoporosis. The good thing is if we can get them on a normal cycle, right? For the athletic women, we can get them on either birth control or something to give them normal, rhythmic, normal cyclic release of estrogen and progesterone, we can offset the osteoporosis. By the way, this estrogen progesterone is so important for bone that when we first, I believe about 25 years ago, 30 years ago, anybody, it doesn't seem like a long time then, right? But I was, about 20 years ago, was my first year of medical school, 21 years ago. And back then, anybody who hit menopause would be given hormone replacement therapy. And usually with hormone replacement therapy, the main purpose was to stop osteoporosis, stop the hot flashes, right? You hit menopause, you're no longer releasing estrogen, you're no longer releasing progesterone to the same levels. So we know women that are that are postmenopausal have increased risk of osteoporosis, increased risk of heart disease, strokes, MIs, right? Even increase some risk of bleeding and cancers. So almost as a fault, any women that hit menopause, we automatically would give them hormone replacement therapy to offset those conditions. Well, what they found out was, number one, yes, hormone replacement was good to prevent osteoporosis. Number two, it actually increased the risk of some cancers. Uterine, ovarian, right? Cervical cancers were all increased. Even breast cancers were increased risk when we give people hormone replacement therapy. We also saw that there was this idiopathic rise in MIs and strokes. So what we thought would prevent MIs and strokes actually caused it to increase. So almost within a year, anybody on hormone replacement therapy was slowly weaned off it. Now, nobody I know is on hormone replacement therapy, right? That's how big of a 180 we did on it. All right, so review these, the type of diseases we see: rickets with the bow-leggedness, with a kind of a bony necklace around the ribs. Bony necklace means that when you touch the ribs, you'll feel bumps, right? It should be smooth, right? Ribs should be flat because they're protective bones. But when you touch it with your fingers, the bony necklace means that you see bumps and feel bumps. Achondroplasia, only the long bones are affected. If you look at the torso between these two boys that are twins, they're pretty similar in terms of the length of the torso. But when you take a look at the humerus, take a look at the femur, the tibia and fibula, right? Huge difference. So it's the long bones that are affected, and it is the actual collagen gene that's been mutated. And with achondroplasia, this is an autosomal dominant disease. If you've ever seen that show Little People, Big World, the mom, Amy, has achondroplasia. The dad has a different kind of dwarfism. Usually when you see two, a man and a wife with achondroplasia, in order for them to have kids, usually they're going to have to be very careful, because with achondroplasia, you only need one of the bad genes. So you need one bad gene inherited from one parent for collagen. If you have that bad gene, then you're going to have achondroplasia. If you have one bad gene from mom and then another bad gene from dad, because both parents are achondroplasic, well, then usually when you inherit two bad genes for collagen like this, it is a genetic lethal disease. Usually kids in utero, they die in utero through a miscarriage, right? So most people don't want to have to, that's pretty devastating to carry a baby and then it dying in utero. So usually they do genetic, all right? Once you have the baby, they'll, kind of do genetic testing. And then if we find out through genetic testing, the baby is homozygous, that means they have 2 of the bad genes, then they can elect to terminate. I know it sounds terrible. All right. So that's it with achondroplasia. That's it with chapter 6. Any questions? Again, chapter 6 will be part of our quiz.